Thank you, Bill. Thank you, all of you, David. I'm excited to be talking about babies with severe BPD and babies like Riley here in this picture where you see him being born extremely prematurely. He was 425 grams, so that translates to under 1 pound, 26 weeks with severe growth restriction, and then requiring chronic ventilation, so being able to discharge home. In this middle picture, he's going to the Irish Fest with his family. And then he's now 8 years old. You can see he has some delays, but he's having fun there. The dad and him obviously took their helmets off for this picture and then put them back on before continuing riding the vehicle. So I have no disclosures. I do want to acknowledge, importantly, with a little story, those of you that have done this work for a while. The story takes place in October 1974, so this is about 11 years after the President and First Lady lost their child, and about 7 years after the paper came out in 1967. So in October 74, San Rafael, California, just north of here, a doctor named John Michael, a neonatologist, delivered another 34-week baby who required 1 week of mechanical ventilation, was discharged before 3 weeks of life, and went on to be standing here right now. So thanks to all of you. So today we'll talk about severe BPD and the definition in a little more detail, and a little bit about respiratory outcomes, and I will ask the question and focus on, can we make a difference for those most severely affected children? So you're familiar with the NIH diagnostic criteria, and specifically the criteria for severe BPD indicate that regardless of gestational age, the need for greater than 30% oxygen, preferably by a physiologic reduction test, or any form of positive pressure support makes the diagnosis. So that, of course, results in a big spectrum of severity. And so these babies all have what we would call severe BPD. So this is a 3-month-old, 26-week girl requiring 1/8 liter nasal cannula, taking full feeds by mouth, ready to go home, and the reduction test results in FiO2 of 0.31, severe BPD. 3.5-month-old, 24-week boy, treated with continuous positive airway pressure of 6 with room air, is fed nasogastrically, unstable when the reduction test was attempted. Or a 4-month-old, 24-week twin boy, early treated with oscillatory ventilation, still intubated on conventional ventilation with a very high inspired oxygen fraction of 80%, frequent desaturation spells, pulmonary hypertension, planned for a tracheostomy. These are all severe BPD, and yet the outcome of the first and third patient is going to be obviously very different. So when we talk of severe BPD and the baby Riley in the first slide, we can think of it as type 1 or type 2. This is a rather new distinction, but type 2 indicating a dependence on positive pressure at 36 weeks. That's going to be the more severe babies. So when I'm speaking about the chronic ventilation and the approaches we use, it's more for treating this more severe form. So this is a baby with what we would call type 2 severe BPD, and I say a new baby with old BPD. You can see findings that are very consistent with the original description: marked overinflation, other areas with atelectasis and scarring, and yet this baby was born just several years ago with extremely low gestational age, and so it obviously suffers from the hypoplasia as well. So when we think of the descriptions of old BPD as an injury to the lung and new BPD as arrested lung development, we have features of both. So the heterogeneity with scarring and overinflation, extensive fibroproliferation, yet still an underlying structure of hypoalveolarization and impaired vascular growth. And so really this type of severe BPD is what we call the worst of both worlds. And so outcomes in this population, you think of general severe BPD outcomes, they're going to need more oxygen therapy, require recurrent hospitalizations and emergency department visits, at greater risk for viral and bacterial respiratory infections. And the effects of lung function have already been described in earlier talks today. But in childhood, BPD in general, patients with very low birth weight would have impaired lung function, such as a decreased FEV1 and hyperinflation. This was shown in a study in Finland. Subsequently, older children at age 9 having also impaired lung function when this was a German study. And then the Epicure study was already showed this morning as well. But babies, very premature babies with BPD also at going through life. And so we're seeing with all these studies ongoing impairment. And I think this study just recently by Lex Doyle in Melbourne is important in that it characterized babies born in these different eras, 91, 92 versus 1997 versus 2005, all studied at age 8 years. And while the most recent babies had many fewer days of mechanical ventilation and more CPAP therapy, the lung function was unchanged. So there's some persistence in spite of all we're doing of this impairment. Here's some outcomes of young adults from the original earlier studies, so quote unquote old BPD, where these young adults at age 18 had up to 76% had some form of airways disease for the BPD infants. And then you see that the preterm controls and the normals didn't have fixed evidence of obstruction, only some amount of inducible obstruction with methacholine. Looking at other adolescent and young adulthood studies, teenagers and followed on to adulthood by investigators in Norway have been shown to have persistent asthma symptoms and impaired lung function, as well as response to methacholine. And again, in Australia, similar type impairments persist both in late teen years as well as early adulthood with impaired lung function. Some of the groups would show persistent air trapping or hyperinflation and others not. But regardless, this disease does tend to persist. But so moving on, rather than focusing on general all of BPD, but these severe patients, how can we make a difference for that type 2 severe BPD? So at some point we need to think about the respiratory support we're providing for them in the NICU. And most of us early on, we think of all of our philosophies are protect the lung from the postnatal injury that we've understood for decades as a part of this disease process. So we want to avoid lung injury, and especially in that fragile immediate postnatal period, we want to have as less invasive approaches. So whether it's the oscillator or early CPAP, small tidal volume, high rate strategies, minimally invasive surfactant therapy, things like using a catheter in the delivery room to administer surfactant without having to intubate and proceeding right to continuous pressure non-invasively. All of these are protective approaches that are of course appropriate early, and yet as the children progress to develop more severe BPD, at some point we need to think about supporting breathing and stop protecting at all costs to, again, have a different goal. So when we think of supportive ventilation, our goal shifts. And it becomes a growing and stable, happy baby that's breathing comfortably, that's thriving, that's not having spells and not having respiratory distress, and more appropriate for this established heterogeneous lung disease. And so we think of larger tidal volumes, lower rates, longer inspiratory times to try to more slowly give a big breath to more evenly distributed amongst that heterogeneous lung with variable time constants. And a lower rate to permit emptying and avoid hyperinflation or gas trapping, a PEEP to treat the dynamic collapse of malacia that we see. And all of this kind of in a different approach, deferring weaning and really saying, okay, we're going to ventilate chronically. And these are the kids where we consider tracheostomy. So in this context, we know the respiratory sequelae of BPD persist into young adulthood, and that the strategies, though, for protecting versus supporting ventilation are very different when it comes to ventilator settings, but more importantly, the goals of care are very different, from avoiding injury to trying to support breathing. And so chronic ventilation can give a baby with the most severe forms of BPD the best chance at a positive outcome. So in Colorado, we formed a Ventilator Care Program to do this, and it started relatively informally. I'd like to acknowledge my mentor, Steve Abman. He really, I think before there was a formal program, would, as a pulmonologist, go to the NICU and talk to neonatologists and discuss the sickest babies and debate about the physiology, and sometimes it was straightforward, other times very complex patients. And there's kind of a shifting philosophy from a protect the lungs at all costs and wean at all costs and never commit to this chronic support, viewing tracheostomy as a failure, viewing chronic ventilation as a failure, but shifting that towards a more supportive approach of ventilation. Jason Geen, a neonatologist of my era, he's a year ahead of me, played a key role in influencing neonatal colleagues at our institution, and it's been an enjoyment to me to be a part of working with these two to form this program, along with so many others at our institution. So the mission of our chronic ventilation program, or Ventilator Care Program, is to provide quality inpatient to outpatient care for these vent-dependent kids. We started with one weekly meeting, we now have two, and it's been since 2007. In the NICU, we round once a week at the bedside so families can participate. Bedside nurses and developmental therapists give us feedback. It's not just about what the blood gas was, but about how the baby's doing and are the changes that we recommend having a positive effect. Who can wean? Who does need chronic ventilation? And having those discussions really at the bedside, trying to decide what's best for each child. And then we have ventilator care rounds outside of the NICU once a week as well, a bit more focused on discharge planning. So this is a big thing that was a transition for our program, is bringing the babies out of the ICU setting to before discharge. And so they come up to our pulmonary pediatric respiratory care unit where they're supported, and the families, the shift goes from life-saving ICU care to really a focus on caregiver education and discharge, arranging equipment, arranging home nursing, all of those details. And so it takes a whole team. I don't just mean interdisciplinary or multidisciplinary when it comes to different physician specialties, which are extremely important, but also nurses, respiratory therapy. I mentioned the developmental therapist, case management, social work. And I mean, the impact is huge. These severe kids have a higher mortality. Their length of stays are very long. It's costly. And of course, it's a traumatic stress for the families. Whether or not they develop true PTSD, I have one patient whose mother says she does from this process. But I think it's a traumatic stress regardless. At our institution at any given time, we have about 15 inpatients and over 100 outpatients, and it's in a 7-state region, so that poses a lot of unique challenges as far as how insurance varies and how the care is different in rural settings. In Colorado, everybody has to have Medicaid to get home nursing. I know every state's different with all those things, but these are logistics that matter. And the discharge barrier really is finding those home nurses even once the babies are stable to go home. So with our program, we showed a decrease in mortality. We see survival here. It was 50% of the 14 babies with vent-dependent BPD in our NICU between 2000 and 2005. So 7 of 14 babies did not survive even to NICU discharge. And now from 2006 to 2013, we only had 15% mortality. Again, I think some of that reflects the change in philosophy of who we're supporting, and still the 15% mortality I think is real. Like, we all remember the babies that didn't survive that had such severe disease. But we hope that with this approach we're making a difference. So we decided to, as we started revamping our process through quality improvement, to kind of keep it in mind as quality improvement rather than clinical research, in the sense that what works in Colorado might not be generalizable to other institutions, and yet we hope that other places can learn from the road that we went down. So process mapping is this business model idea of increasing efficiency and putting Post-its on the wall to define every single step of a process to make it be efficient and define roles, have things not be overlooked, and I think importantly in the medical setting to make sure it's safe. It focuses on care coordination, and case managers are huge, and lets each caregiver, including the family, know their responsibilities. So we developed a standardized process, which I feel is oxymoronic in the sense that all the babies are so different that families will say, well, you have this standardized thing. My baby's different. My baby's different than everyone. And I say, I humbly know that. Like, there's no baby that's the same as another. They all require customization, but there are steps of this process that are always the same, and standardizing that is helpful. And so we used our process map to then create a family-friendly roadmap. And doing this, kind of all the steps in together, resulted in a marked decrease in the length of stay. So for chronically ventilated children, the overall length of stay decreased by 42%, and the time after ICU transfer decreased by 55%. So this is the process map we generated, and I'm going to use the whole rest of the afternoon to go through every box. You probably can't read any of it, but the very last box at the top right, yellow box, says surgery completed. So there's a whole slew of steps before a tracheostomy is done. And then onward, a bunch of steps with all the different colors reflect different caregivers, including the family, and all working to get home. And so this is the fun version, which we have in English and Spanish, which we laminate and put in the patient's rooms. And really with the goal of education all throughout the process, and to get them home and safe at home. Caregiver education is key, and RT and nursing take the lead on that at our institution. Comprehension is really our focus. I say you don't just walk in a room and say something, they have to learn it. And so we have to verify that with the teach-back method. So whether it's verbal or written, hands-on, we have bilingual videos, CPR training, simulation I'll talk a little bit more about, and really focusing on other special learning needs too. So recently we discharged a Mongolian speaking only family with chronic ventilated baby who's doing great. And that of course posed unique challenges. Or illiteracy or dyslexia, things where maybe checklists or timelines, color-coded medications. We really work with our families as much as possible, and of course home nursing plays a big role. Education, like Tyler here at his desk, ready to learn. So simulation. So the goal of our high fidelity simulation, which is of course used in all sorts of medical settings, mostly to train trainees or students or EMS, core code scenarios. Our hospital has an active simulation lab, but we started using it to train family caregivers in order to simulate the emergencies. So really a key part of that process is debriefing after. And the two scenarios we have are the trach being plugged or the ventilator malfunctioning, which progresses to full CPR and them having to call 911. And we've done over 50 children, over 100 caregivers. And so we try to do that close to discharge so that they are feeling confident going into it, and it reaffirms their skills rather than too early and they're not ready. It's to identify gaps in understandings, and we say it's not pass-fail so much as enables this opportunity to learn. And the limitations are that it's expensive, and the availability both of staff and that we just have one sim lab, so we can't be doing it repetitively for multiple patient or multiple times for the same patient. But this has been improved in University of Alabama. A group showed that self-reported caregiver confidence was improved with simulation training, and that was in the same population. And then we showed earlier this year that caregivers described the debriefing process after sim as the most beneficial part of all of their training. So in summary, chronic ventilation is helpful for the most severe lung disease. It can improve over time. The collaborative approach is key. I often say it's the people, not the map. People will ask me for that process map. We published it to share. That's all fine, but it takes the team of people that are passionate about these patients and people in all disciplines working together. Repetition is key for the education process. The outcomes can be improved with a standardized approach, and it really does take a village. So I asked the question, should we chronically ventilate infants with severe BPD? And these pictures are similar to what Dr. Newman showed us earlier, but from Rob Castile at the University of Ohio that Steve shared with me. And this baby has severe BPD at age 6 months, and you see how severe this CAT scan is of the lung regions with areas of overinflation and the scarring like we're used to seeing. And at age 14 months, improvement, and then onward to see it almost age 2 years. Far from normal, still much scarring, much hyperinflation, but dramatically improved and a much greater amount of parenchyma for gas exchange. So in this process, I get to watch babies go through this process. So this is Cora, who, when she first went home, her parents did this little photo shoot for her. They said "little low peep," which I thought a little corny, but pretty great. And here she is on her first birthday. here she is in clinic, and she's decannulated now, and as a pulmonologist, I get to watch her grow up. So, thank you.